Okay, well, why don't we go ahead and get started since it's a little bit after 6 Central Time. I've got a little bit of a long presentation, so we'll try to get through it in a reasonable fashion here. So just to start, my name is Gina Lockwood. I am a pediatric urologist in Iowa City, Iowa, and I have been out of fellowship for about 3 years now, so relatively junior faculty, definitely still junior faculty at this point. And thank you guys all for listening in today. I realized that I did not put my email address in this presentation, so I will make sure to give you guys that at the end of the presentation. If you have any questions about my presentation, I will also get you those slides for your consumption. And if you have any questions about that or any questions about Iowa or our program, I am more than happy to communicate with you. We have the Q&A function at the bottom of the screen. I probably will wait until the end of the presentation just to answer questions, just so we can kind of keep the flow going, but please feel free to ask any questions that you might have. Kind of selected a broad topic today and something that I am sure you are all very well versed with. Going to talk about ultrasound in peds urology, and specifically the latter half of the presentation is going to focus on classification of hydronephrosis. I will start out by saying that hydronephrosis and urinary tract dilation, I'm going to use interchangeably throughout the presentation. We are really trying to use the UTD classification system, but it's really hard to teach an old dog new tricks, and I still say hydronephrosis, and I'm still not broken of that habit. So just know that when I say hydronephrosis, I mean UTD and kind of vice versa. So let's get started. I don't have any pertinent disclosures or conflicts of interest. This is a picture of our children's hospital here in Iowa City, and it is immediately adjacent to Kinnick Stadium, where the Hawkeyes play football. Not so sure if it's going to be happening this year. We will see. But the fans in between the quarters wave up to the kids in the children's hospital, as you might have seen on ESPN. So it's a pretty cool place to be. Okay, so just getting started with some objectives, we're going to discuss kind of basic principles for renal ultrasonography, specifically in children, and some pearls. This is something that I know most of you deal with on a very regular basis, so hopefully I'm not telling you too many things that you don't already know. We're going to specifically talk about the grading systems for urinary tract dilation, specifically just looking at anterior posterior renal pelvis diameter, as well as the SFU grading system and the UTD classification system. We'll kind of discuss why these different grading systems are important, what their differences are, and how they can be utilized in your practice. So this is just a pretty extensive list of indications for ultrasound in children. Again, today I'm going to be focusing on renal ultrasound and ureteral ultrasound for the most part, but we also use ultrasound in urology for other indications, including scrotal masses, and just because of its, ease, lack of radiation, and cost. So these are indications for ultrasound in kids, definitely not an exhaustive list by any means. I'm sure there are other indications that you can think of. Okay, so when specifically thinking about what should be included in a renal ultrasound, or likely what's called a retroperitoneal ultrasound at your institution, as you think of it, most of the time that includes the kidneys, the ureter, and then the pelvic organs. And this is just a list of what often radiologists focus on and what can be pertinent to us in practice. I'm not going to read these to you, but I know at my institution, these are all things that are in our radiologist templates and things that they specifically comment on for us. Okay. So just thinking of what a normal renal ultrasound looks like, starting in infancy, because most of the time when you guys are going to be evaluating and interpreting renal ultrasounds, we're going to be looking at these oftentimes in infancy because of a diagnosis of prenatal hydronephrosis or some kind of congenital malformation. So I think that infant renal ultrasounds are really important to understand because they can be very different than ultrasounds in older children, adolescents, and adults. So I just thought it was important to go over some pertinent points. So obviously here is the outline. This is actually the left kidney in an infant. And this is, kind of parenchyma extending out here. And so the first thing that you notice in this ultrasound is that fetal lobulation of the kidney is still there. When you see an adult ultrasound of the kidney, you usually don't see this lobed appearance. That is due to incomplete fusion of the renal lobes, and usually that disappears by age 5, but that can be considered a normal variant. The other thing that you notice in ultrasound in infants is that the cortex, the renal cortex, is going to be more echogenic. And we will look at some more examples of this. You know this, but hyperechogenicity is bright or white on an ultrasound. Hypoechogenicity on an ultrasound is more dark, and anechoic is going to be black. So the cortex in an infant kidney is going to be more echogenic than in an older child or an adult. And so what we usually compare echogenicity to in the kidney is to either the adjacent liver or the spleen. So in older children and adults, often the kidney is hypoechoic or a little bit darker compared to the liver of the spleen or the spleen. But in infants, it can either be isoechoic or sometimes it can be even slightly hyperechoic. And that hyperechogenicity doesn't usually decrease compared to the liver until 4 to 6 months of age, sometimes even up to 12 months. The other thing that you notice in infant ultrasounds is that the medullary pyramids are much more prominent. Usually in older children, those medullary pyramids kind of go away. And so they create this corticomedullary differentiation that you hear about. So here is cortex of kidney here as opposed to the medullary pyramid, and you see this distinct differentiation. And that's actually a sign of good renal health in infants. That can make things a little bit difficult when trying to differentiate between good corticomedullary differentiation and hydronephrosis, and that differentiation can sometimes be exaggerated in infants. The other thing is that when I was always taught that in a normal kidney without hydronephrosis, you're going to see this white stripe, which you don't see on this slide. You're going to see this white stripe kind of in the center of the kidney that represents the renal sinus fat. And as soon as that sinus fat starts to split, that's when you get hydronephrosis. But in infants, oftentimes you don't see that white stripe in the middle. So that's important to be aware of as well. One other important comment on infantile ultrasound is that often babies are dehydrated in the first 2 days of life, so that can mask hydronephrosis within the first 48 hours of life, which, as you know, is an important clinical concept. Okay. So moving on to normal sonographic measurements for the kidney. So something that I always follow along in kids who I am seeing for prenatally diagnosed hydronephrosis, history of reflux, urinary tract infections, things like that, is as they grow, are their kidneys growing symmetrically and growing appropriately? There is not a perfect algorithm for measuring renal length. And in fact, renal volume is actually a better surrogate with renal function than renal length actually is. In my mind, and it has been shown that there shouldn't be a discrepancy in renal length of more than 10%. If there is, that indicates that there might be a problem. The number that I always had in the back of my mind was a centimeter, but that's a little bit on the high side, especially in young children. The other thing that we'll talk about is that the anterior posterior diameter of the renal pelvis should not generally postnatally measure more than 1 centimeter. And we'll talk about that more with hydronephrosis. Normal ureteral diameter rarely exceeds 5 millimeters. As you know, oftentimes with pelvic ultrasounds, you cannot visualize the ureters. And in fact, visualizing the ureters does indicate some degree of dilation or pathology. Bladder wall thickness is a little bit of a tough one. You know, that definitely depends on distension of the bladder. But when the bladder is fully distended, generally the upper limit of normal for bladder wall thickness is 3 millimeters. In a non-distended bladder, that wall is going to appear thicker, and it's considered to be normal up to 5 millimeters. Okay. Moving on, there are definitely some normal renal variants that you can see in infants and in children, including, you know, those fetal lobulations like we talked about. This is a picture here of a hypertrophied column of Burton, which is basically just kind of cortex extending through the medullary area. It's a little bit difficult to discern on this picture, but that's a normal variant. Just in the interest of time, I'm not going to go through all of these. Okay. The latter part of the lecture is going to focus on prenatally diagnosed hydronephrosis and classification for that. But before we get into those, I wanted to comment on some common renal ultrasonographic abnormalities that we see in infants that can be difficult to differentiate, and things that you can look for on renal ultrasound that help you to distinguish between them. So with renal cystic disease, the most common entity that we see in pediatric urology is multicystic dysplastic kidney. That often can be difficult to differentiate between severe hydronephrosis, but generally what you'll see, this is a picture of MCDK right here, multiple non-communicating cysts of varying sizes. That's the important word, is non-communicating. So when you scroll through the ultrasound video, if there appears to be any communication, that can be more consistent with hydronephrosis or urinary tract dilation. Other types of renal cystic disease include autosomal recessive PKD, ADPKD, simple cysts, calyceal diverticula. This is a picture down here of a multilocular cystic nephroma, which is a common kind of tumor, but it's not really a tumor, seen in infants. And that will appear as a multicystic mass with internal septations. This is a picture here of cystic renal dysplasia, which sometimes can be confused just because of nomenclature with MCDK. And cystic renal dysplasia can be caused by lots of different things, usually obstructive uropathy in infants. And as you can see, you kind of see this hyperechoic kidney that is indicative of medical renal disease with small cysts throughout the cortex and the medulla. Okay. So focusing specifically on echogenic kidneys, I won't go through all of these causes. As you can see, there is an exhaustive list of things that can cause hyperechoic kidneys. And as I stated before, kidneys in general should be, after 4 to 6 months of age, hypoechoic compared to the liver or the spleen. In infancy before that, they can be somewhat hyperechoic, but as seen in this picture, this is a very hyperechoic kidney, and it generally indicates some type of glomerular disease, if seen especially in the cortex. If there is hyperechogenicity specifically in the medulla, then that can sometimes be consistent with collecting system abnormalities like hypercalcemia or nephrocalcinosis that we'll look at in further slides. Small echogenic kidneys are usually associated with some type of cystic dysplasia and can indicate poor renal function and renal scarring in older kids. Okay. Very briefly, there can be whole lectures on ultrasound looking for stones, but this was something that we often start with renal sonograms to diagnose stone disease in kids rather than CT scans. Some important things to remember when using ultrasound for stone diagnosis is that sonograms can often overestimate stone size. It depends on the technician and the position of the patient, but that's something to keep in mind. Sometimes the acoustic shadow that you can see adjacent or posterior to the stone is actually more representative of stone size than the actual stone measurement itself. And acoustic shadowing usually can be seen in stones greater than 5 millimeters in size. You guys have probably heard of something called twinkle artifact, which is when you use Doppler flow on stones and you kind of get this crazy color pattern within that acoustic shadowing. And that is just kind of the reflectivity of the stone, this very reflective surface, and it's imitating turbulent flow. And so Doppler can be very helpful in diagnosis of stones as well. Last entity that I wanted to talk about specifically was medullary nephrocalcinosis. As opposed to that previous very hyperechoic kidney kind of throughout, you can still see in this picture that corticomedullary differentiation is somewhat preserved. You can tell that this is cortex versus this being medulla, but the medullary pyramids are very hyperechoic. And when you see that hyperechogenicity in the medullary pyramids, that should raise suspicion for nephrocalcinosis. I didn't realize this until today, but there's actually a grading system for nephrocalcinosis that we're not going to get into. And here are some causes below. This would be grade 3. This is pretty severe. Okay. So shifting gears a little bit, presumably the most common thing that you will be using in future practice for renal ultrasonography is detection and surveillance of urinary tract dilation or hydronephrosis in kids. And I know that in my clinics, this is one of my most common diagnoses. So prenatal urinary tract dilation or hydronephrosis is diagnosed in 1 to 2% of all pregnancies, which is a lot of kids every year. It's the most common abnormality in the fetal urinary tract, and so we can get a lot of prenatal referrals for this. It can become apparent on the sonogram from the beginning of the 2nd trimester. It usually is recognized in new moms on a 20-week kind of anatomy scan, and depending on the severity of that hydronephrosis, it's decided upon how closely to follow that prenatally and postnatally as well. As you know, possible etiologies of prenatal hydronephrosis are listed here. When I talk to parents, I kind of break it down into that transient or physiologic hydronephrosis, which we don't really know what the cause is. Potentially, some kind of mild obstruction within the urinary tract or some kind of kink or bend that eventually resolves on its own, versus obstructive uropathy like UPJ obstruction, UVJ obstruction, ureteroceles, things that don't go away over time, and then also vesicoureteral reflux. Okay, so the problem is, if children are diagnosed with mild versus severe prenatal hydronephrosis, how do we determine which kids going forward are going to eventually have their hydronephrosis resolve if we follow it over time, or who is ultimately going to need antibiotic prophylaxis, who is going to need surgery because they have a UPJ obstruction or they have posterior urethral valve? The problem with our literature looking at those outcomes has really been a lack of uniformity on how to define prenatal and postnatal hydronephrosis. There has been somewhat of a lack of communication between prenatal providers, postnatal providers, and a lack of standard definition of outcomes. We also know that urinary tract dilation is dynamic. It can vary based on hydration. It can vary from one day to the next. It can vary based on the technician doing the study. And uropathies can present with different spectrums of severity. As we know, hydronephrosis doesn't always correlate with things like reflux. And so this has created problems with our being able to adequately use hydronephrosis as a predictor for outcome. Okay. So in general, traditionally, obstetricians prenatally have used the AP-RPD or APD classification for anterior-posterior diameter of the renal pelvis to assess degree of hydronephrosis prenatally. And so if we use kind of the most used systems for this, these are the definitions of hydronephrosis in the second trimester and the definitions in the third trimester. And a lot of studies, including meta-analyses and systematic reviews, have looked at the ability of that anterior posterior renal pelvis diameter to predict for true pathology down the road. Which kids are going to need surgery, which kids are going to have a clinically significant problem. And as you can see, as the anterior posterior diameter kind of cutoff increases, the positive predictive value for pathology goes up. But that's not necessarily a super helpful thing, because as that APD increases, you're also, or decreases, you're increasing your risk for false positives. And so the other problem with the anterior posterior renal pelvis diameter alone is that it's only one measurement. So it doesn't account for ureteral dilation. It doesn't account for oligohydramnios. And so that one measurement in time is potentially subject to a lot of error. Okay. So again, this is just kind of reiteration of that last slide. And basically, all of our data that is somewhat flawed has shown that the larger the anterior posterior renal pelvis diameter prenatally, the more likely that there is going to be a diagnosis of obstructive uropathy down the road. There's a decreased rate for spontaneous resolution, and there's a higher risk of surgery postnatally. We're going to get a little bit into this next statement more on the next slides, but we also know that when you measure the anterior posterior diameter postnatally on that first ultrasound, we know that there is also an increased risk for these things. But what we have found is that ureteral dilation, parenchymal thinning, renal hyperechogenicity, and a thickened bladder are also independent predictors of pathology. Okay, so this is changing gears a little bit. In 2010, the SFU created a consensus statement for prenatal evaluation of hydronephrosis and essentially used those APD parameters and gave guidelines to the obstetric community as to how often to obtain prenatal ultrasounds going forward. Ultimately, guidelines for postnatal evaluation were also created in 2010. And as you can see, this is a really complex algorithm. And at this time, they were using kind of a mild, moderate, severe classification system for hydronephrosis postnatally. And then we're giving recommendations based on that. But then they also had all these other things added in. Okay, so you have moderate hydronephrosis, but you also have bladder wall thickening or a diverticulum. Well, that changes things. Then you should do X, Y, and Z. So these these recommendations just illustrate the need for an accurate and standardized system from the prenatal setting to the postnatal setting when diagnosing these kids. If we are overdiagnosing urologic pathology when children are diagnosed with prenatal hydronephrosis, this is a cost to the patient and this is a cost to the healthcare system. You, I'm sure, have all seen kids who come to your clinics that you are following them with ultrasounds over time, and no one really knows the right way to do it. But every time they have to come in, they pay for that ultrasound, they pay for potentially travel. I know in Iowa, that's a big deal. We have people coming to us from multiple hours away. They're paying for loss of work. Parents often don't understand why they're so closely following up. And then if they need additional studies like VCUG or MAG3, they're potentially getting more radiation. And they may get unnecessary antibiotic exposure as well. If we underdiagnose urologic pathology, then this is obviously where the true pathology comes into play. We may be missing urinary tract infections and ultimately effects on renal function. Okay, so what grading systems do we have and how can we make those better? How can we better evaluate renal ultrasonography to use for our advantage to help predict outcomes, to help counsel parents? So there are a lot of grading systems out there. There was a study in, I believe, 2015, surveying pediatric radiologists throughout, I believe, the United States, and I think it was 19% of radiologists responded, and 66% of those radiologists were using just a mild, moderate, severe hydronephrosis classification system. Almost 40% were just using APD. 35% were using SFU. You'll notice that these don't add up to 100. People were using multiple systems. There were other grading systems in place as well. And all of these grading systems have somewhat suboptimal inter-observer reproducibility. They were asked the question as to whether a unified pre- and postnatal classification system for urinary tract dilation would be beneficial, and about 90% said yes, that would be beneficial. Okay, so just a couple polling questions for you guys. These aren't quiz questions, but just asking at your institution, I believe the first question is, what hydronephrosis grading do you use? If you are a pediatric urologist, which system do you use? And if you don't use one of these systems, just click other. I'm just curious as to what you go by. I think you've got 20 seconds. Okay. So I've got 20% APD, 54% SFU, 17% UTD, 6% mild, moderate to severe, and 3% other. When I was in fellowship, we used the SFU grading system, and so that's my default as well, and that is pretty consistent with what I thought you would say. The next question is, it may be the same at your institution, it may not. Pediatric radiologist at your institution, what system do they generally use? Okay. So UTD is pretty similar. SFU is pretty similar. I think slightly more are using APD and slightly more are using mild to moderate to severe. When I came to Iowa, I was very used to us being consistent with the pediatric radiologists and using the same classification system. And when I got to Iowa, they were using mild, moderate, and severe, which was definitely something that I had to get used to as well. Last question I'm going to ask you guys is your obstetricians, what are they generally using in practice? From what you understand, if you do see prenatal consultations. If you don't feel the need to respond. Okay, well, that's interesting. So 25% APD, 41% SFU, very small percentage using UTD. At our institution, the obstetricians generally use anterior posterior diameter. Okay, great. Thank you guys for indulging me. Okay, so, we talked a little bit about the anterior posterior diameter system. So the SFU grading system was created, I believe, in 1993 to address some of these concerns that really we were just looking at one measurement. And what the SFU grading system brought into play was looking more at major and minor calyceal dilatation as well as parenchymal compromise. So these pictures are from Seville for Healthcare, Dr. Meisel's at Lurie Children's educational website that is actually very helpful if you guys haven't checked it out for SFU hydronephrosis grading and UTD hydronephrosis grading. One of the problems cited with SFU grading has been that there is a relatively low inter-rater reliability. There can be difficulty differentiating between parenchymal compromise at just one area of the kidney versus the whole area of the kidney, and often there is a discrepancy when people are identifying major calyceal versus minor calyceal dilatation. So this is a picture that I brought up actually from Seville, and pretty standard picture of a renal ultrasound, and I just wanted to get your guys' opinion as to, using the SFU criteria, what you would grade this in terms of hydronephrosis. Yeah, so I would call this SFU grade 2, and this is what it was listed as on the website. We'll go to the next slide, which kind of defines things a little bit differently. But so the important things to note in this ultrasound are we've got the renal pelvis that appears to be dilated here, extending out to the major calyces that kind of stop here. What you're likely seeing out here in the periphery, which can be easily confused with peripheral calyceal dilatation, is normal renal pyramids. But if we look at the next slide, nope, sorry. If we look at the next slide, this educational course has it outlined pretty well. So they're calling this renal pelvis, this major calyces, this minor calyces, and these are renal pyramids out here. And then there's normal renal parenchyma out here in the periphery. Again, very subjective. So this is just one more example of this. If you were looking at just this one picture, what would you classify this degree of hydronephrosis? And I think this will be the last poll question. Okay. So 54% say SFU grade 4, SFU grade 3, 37%, and fewer on the rest. So Seville actually classifies this as SFU grade 3. I think this one can definitely be deceiving because the renal pelvis is obviously huge. And you see that degree of dilation, and I know in my mind, I automatically go to grade 4 as well. I think this is definitely a tricky one, but I think the point that this one was trying to hit home is that it appears here, if you really do look at the renal parenchyma, you still do have relatively normal renal parenchyma here, and you can still see that cortical medullary differentiation. This is not perfect by any means, and this is not cut and dry. The whole point of these slides is really to just illustrate that two different people looking at an ultrasound using SFU grading or any type of grading really could easily call it two different things. Okay, so, you know, we've done a lot of studies looking at anterior posterior diameter. We've done studies looking specifically at SFU grading. And what do we know about SFU as a predictor for outcomes? Not a whole heck of a lot more than we know with anterior posterior diameter. We know that severity or an increasing grade does correlate with urological pathology, except for reflux. We know that you can have relatively severe reflux and have very minor or no hydronephrosis, and vice versa. You could have a severe hydronephrosis and not have any vesicoureteral reflux. A few studies have shown that if you combine the SFU grading as well as the anterior posterior diameter, they predict a lower likelihood of resolution if the APD is high and the SFU grade is high. Okay, so since a lot of these systems have not been considered perfect, we're still striving to find the best system to analyze hydronephrosis and use it as a better predictor for kids going forward. The other thing is creating a system that can be standardized between the antenatal period and the postnatal period. And so this is where the UTD classification system came in. And so there was a multidisciplinary consensus statement in, I believe, 2014, where the UTD classification system was kind of first published. And it looks at all of these parameters. So not only APD, but also looking at calyceal dilation, also looking at parenchymal thickness and appearance, but then specifically figuring in the appearance of the ureter and bladder too, which is really what the other systems had not done. And these are just kind of guidelines as to what to look for on ultrasound to accurately measure these. Okay, so this is a picture, this is just a table from that publication in 2014. This is what is considered normal prenatally and postnatally for all of those parameters for the UTD system. Okay, so these are the prenatal classifications. So the UTD grading system is split into UTD-A for antenatal and UTD-P for postnatal. And so these are specifically the prenatal guidelines, and they have two kind of risk categories. There is the low risk category, or A1, which is really just based on the anterior posterior diameter being relatively mild, depending on the gestational age, versus the increased risk category, in which the AP diameter is moderate or severe, or has any of these other abnormalities. Those automatically put these kids in a high risk category. Even if the AP diameter is small, but they have ureteral dilatation or the bladder appears normal, that automatically puts them in a higher risk category, which gets them more prenatal ultrasounds to follow as they continue to grow, as well as postnatal consultation with nephrology and urology as kind of outlined here. Okay. The postnatal UTD classification, or UTD P1, P2, P3, is similar to the SFU system in that UTD P3 is analogous to SFU4, UTD P2 is analogous to SFU3, and UTD P1 is analogous to SFU2, except for the same thing. If there is peripheral calyceal dilatation, or your ureters are abnormal, or if the parenchyma appears abnormal, or if the bladder appears abnormal, it automatically elevates you into a higher risk category. And the interesting thing about this is what we would consider SFU grade 1 would be considered a normal postnatal ultrasound if that's the only abnormality in this scheme. That's been something that's hard for me to accept. I've always called SFU grade 1 real hydronephrosis that needed to be followed, and using this classification, that doesn't necessarily need to be followed after birth, depending on clinician discretion and the overall clinical picture of the child. So as you'll see here, the kind of poor prognostic factors automatically put you into the next category. So you could have a anterior posterior diameter of less than 10 millimeters after birth, but have an abnormal ureter, and that automatically puts you into that high risk category. And then that dictates what further postnatal management should be. Now, this classification needs to be studied in more detail, and this is by no means a rigid algorithm to how to proceed with these kids, and this likely will continue to change and evolve over time, but this is just kind of general guidance for the clinician. Okay, so I didn't give you guys poll questions for these, but just briefly looking through the UTD classification. So this first picture is what would be considered a normal postnatal sonogram. So on the longitudinal view, there is a kind of small splitting of the renal sinus fat, which would, to my eye, normally be considered SFU grade 1 hydronephrosis. And then on the transverse view, the anterior posterior diameter is less than a centimeter. It's 3.5 millimeters. And so this would be considered normal, assuming that the ureters and the bladder are normal. So this would be considered UTD P1, renal pelvis dilation here, some central calyceal dilatation, but really not dilation extending out into the peripheral calyces. And it doesn't matter here that the anterior posterior diameter is less than a centimeter, because you have this central calyceal dilatation. It elevates it to a P1. This is considered UTD P2, so normal appearing renal parenchyma right here. You can see these normal medullary pyramids, but there is extension of the hydronephrosis out into the peripheral calyces. The anterior posterior diameter here is high. It's greater than 15 millimeters, and so this would put you in the moderate risk category of P2. Okay, and then this is P3, so again, somewhat analogous to SFU grade 4. So abnormal appearing parenchyma here, thinned parenchyma, what appears to be a cyst indicating potentially not good renal health, and then some increased bladder wall thickness, which would put this in the high risk category. Okay, so is this classification system really any better than the previous classification systems? I think the answer to this is that time will tell, but it definitely brings more of the variables that could portend a poor prognosis into the mix. There was a study in 2018 at CHOP looking at the renal ultrasounds of about 60 infants, and the inter-rater reliability was improved compared to the SFU grading system. The intra-rater reliability, which was pretty decent in the SFU grading system, was similar. And again, that calyceal dilatation, differentiating between the major calyces and the minor calyces, is the biggest break point for people. Okay, so how can we use these classifications to our benefit going forward? Looking at the literature since the UTD classification has come out, still not a lot of centers are using it. More and more academic centers, this is becoming the norm. I recently looked up some numbers today, and I think there was a literature review in 2020 out of Michigan that looked at 197 articles over the past few years looking specifically at hydronephrosis. And 5.6% of those articles referenced the UTD classification system. 37% were using SFU, 32% were using the APD, and 20% didn't use any classification system, or were just using like a mild, moderate, severe classification system. So testing on outcomes going forward with this classification system is needed. And we also need better defined outcomes, or we need better defined outcomes across institutions. There is a hydronephrosis registry, which is a prospective registry of patients with upper urinary tract dilation that is multi-institutional. I don't know how many centers there are now, but these are a few of the articles that have come out in recent years, specifically using the UTD classification system and using prospective data regarding kids with prenatal hydronephrosis so that we can better predict outcomes for these patients. Unfortunately, we've had recent meetings canceled, the AUA and the SPU. These are a few abstracts that were recently accepted from this hydronephrosis registry, again, that can kind of shed some light on this issue. So I think at the end of the day, we still have a lot of work to do. Pediatric urology is such a small field, and we need to better collaborate with our partners to get good data. And hopefully these types of standardized algorithms can help us to do that. Okay, so now that we've been talking for 45 minutes, 50 minutes about ultrasound and prenatal hydronephrosis, I hope you guys aren't asleep. This is my daughter B. She fell asleep eating 2 days ago, so hopefully some of you are still awake. I'm going to go to the Q&A section and go take a look at the questions you guys have posted. Okay, so talking about renal ultrasound, do you think it is important to look for ureteral jets intentionally? I am definitely open to hear your guys' comments on this. This was not something that I ever thought it was important to visualize. Sometimes in the setting of obstructive stone disease, but it's not something that I pay a whole heck of a lot of attention to when I look at renal and bladder ultrasounds. I feel like it is very technician dependent, as well as time dependent. Sometimes, technicians will spend a lot of time looking for ureteral jets and some won't. And how long is the magic number that you need to wait to see a ureteral jet? So it's not something that I put a lot of stock in. How are the resistance indices considered in the renal ultrasound? So no, that's a very good question. We didn't talk a lot about Doppler and the resistive indices. Those definitely can be markers of medical renal disease and can be extremely useful in renal transplantation, diagnosis of renal vein thrombosis, renal artery thrombosis. Generally, from a urologic standpoint, when I'm thinking more about urinary tract dilation, it's not necessarily something that I am as well versed in evaluating myself. Why do you think people are shifting towards the UTD system? How does it benefit us more than the SFU grading? And that's a good question. I think that people are drifting more towards the UTD system just because it has been it is a good way to create a dialogue between prenatal providers and postnatal providers. It's just the fact that we, can have a standardized system that allows crosstalk between the two. But I think time will tell whether it's really better or not. Do you have a cutoff number for pyeloplasty in an asymptomatic patient? So I don't necessarily have an anterior posterior diameter cutoff. Usually my algorithm, whether right or wrong, for moving forward with a pyeloplasty is really more based on function at the end of the day. If function is stable, and I have been following a kid for some time, and parents are getting antsy, generally just worsening hydronephrosis over time, regardless of the actual number, will to help make the decision to proceed with pyeloplasty. I don't have one number either way. Any other questions? I'm happy to take. Okay. If you guys do want to reach out to me privately, I am more than happy to talk to you about this or any questions that you have about my practice or, again, University of Iowa, pediatric urology in general, jobs, all of that kind of fun stuff. I'm more than happy to talk to you. Let's see, my email address is Gina-Lockwood, LOCKWOOD @uiowa.edu if you guys need anything. And for the PedsUroFLO lecturers, if you could take this survey after you guys are done, they would really appreciate it. Thanks so much for hanging out this evening. Hope you guys have a good night and stay healthy. Thanks much.